Welcome to the CJASN podcast. I'm Dr. Nazleen Khan, an epidemiologist at Merck & Company, Incorporated, and previously part of the research team at Brigham and Women's Hospital in Boston, Massachusetts. And I'll be discussing research done during my time at and in collaboration with colleagues at the Brigham and Women's Hospital, including the corresponding author, Dr. Julie Paik. We want to talk today about osteoporotic fractures, which lead to significant health burden in patients with atrial fibrillation and chronic kidney disease, or CKD. In fact, CKD patients have more than 2 times the risk of hip fracture compared to patients with normal kidney function. Many of these CKD patients with atrial fibrillation also take anticoagulants to prevent embolic events. So far, we have very little understanding of whether anticoagulant therapy further increases fracture risk in this already vulnerable population. Direct oral anticoagulants, or DOACs, have been shown to lower the risk of fractures compared to warfarin in patients with atrial fibrillation overall. What's not clear is how the different anticoagulants fare in a subgroup of patients with CKD. To understand these risks, we conducted a cohort study using a large administrative claims database in the U.S. comparing fracture risk for select DOACs and warfarin in patients with CKD, stages 3, 4, or 5, and atrial fibrillation. We identified individuals based on their first dispensing for apixaban, rivaroxaban, or warfarin at age 50 or older immediately after 1 year of health plan enrollment with no anticoagulant use. We further restricted to patients with at least one diagnosis code for CKD, stages 3, 4, or 5, and atrial fibrillation during the 1-year baseline period. We estimated a relative risk of non-vertebral fracture between patients initiating select DOACs and warfarin using a 1-to-1 propensity score match design and Cox proportional hazards regression. Secondary analyses evaluated risks of hip fracture and all-cause mortality. We identified over 14,000 DOAC and warfarin initiators, respectively. The average age at anticoagulant initiation was 77, and 45% of patients were female. In patients with both CKD and atrial fibrillation, we found no clinically meaningful difference in fracture risk between DOACs and warfarin. However, these results may have been underpowered because of the small number of fracture events. DOAC relative to warfarin use was associated with a lower risk of all-cause mortality. This posits that close monitoring of patients with CKD and atrial fibrillation might be needed at the time of anticoagulant initiation to prevent adverse clinical outcomes. We thank the Clinical Journal of the American Society of Nephrology for the opportunity to share our research. We hope these findings spur dialogue to improve care for CKD patients.
This podcast is copyrighted by the American Society of Nephrology. All rights reserved. All content in this podcast is for informational purposes only and is not intended to be medical advice. This podcast should not be used in a medical emergency or for the diagnosis or treatment of any medical condition. Please consult your doctor or other qualified healthcare professional if you have any questions about any medical condition or before taking any drug, changing your diet, or commencing or discontinuing any course of treatment. Thank you for listening to this podcast from the American Society of Nephrology.